Hello, everyone. We're going to get ourselves started. Hello, everyone. Welcome to another program at our great Young at Heart. So nice to see you all, and we're really excited to be able to see you several times a week, and we look forward to be able to add more, but also soon we'll be able to do it in person. But meanwhile, this is the best that we can do, and we're so happy to have you all. As I said before, in a moment before we start and introduce our guest, I want to just share a few things. Number one, I would love everyone to unmute yourself and just introduce your name so everybody around knows who everyone is. Secondly, we're trying to do a little drive and a push to get more people registered to Young at Heart. So we'd love your help. Tell your friends. It's obviously, there's no cost. And we're going to be doing more and more things as we go on. Very fascinating programs and speakers like we're going to have today as well. We're having on here. We'd love every one of you to try to get one or two more people to come on and to try it and to be part of the community that we're building and growing. And we really look forward to not only coming and just listening to things, but creating a sense of camaraderie and community. So please, tell your friends, chabadtmr.com/YAH. It's in all the emails that we send out. Send it to a friend or two. Help us get more people, give more people the opportunity to be part of what we're doing. So let's take a moment quickly and unmute and announce your name. Morty, you start.
Okay. Morty Berkowitz, Montreal, Canada.
Oh,
Beautiful. Sydney.
Sydney Silkoff.
Beautiful. Lillian.
Lillian Levy.
Beautiful. Laura. You able to unmute yourself, Laura? We'll go, Lily.
Lily, unmute.
Yeah, all muted. You have to unmute yourself. You know how to unmute yourself?
There she
Hello.
Yeah. Introduce yourself. Tell us who you are. Let everyone know who you are. Lily, tell us your name.
Yeah, Lily Mawas.
Welcome. So nice to have you.
Thank you.
Okay. Abadis, tell us your name. No, you have to unmute yourself. You're still muted. Okay. Ellie, meanwhile, Ellie, tell us.
Ellie Levy.
Beautiful. Dalia.
Dalia Urman.
Beautiful. Okay. And Laura, I see you have a hard time. Laura Wienerman and Shella and Shah Abadi and Claudia, I don't see her there. And Dalia Rashi just came in. And I want to take a moment to introduce, we have with us here today, Dr. Dan Liberman. Dr. Liberman had actually been in Toronto for a number of years, but we're lucky to have him back in Montreal. And very much in the world of geriatrics and here to help share with us and educate us things that are important for all of us to know, to have a healthier and better life and for many, many more years. So now you should all please mute yourself. So no distractions. And if you want to ask a question, Dan will let know if he takes them at the beginning, in the middle, or at the end, whenever Dan will take over. Dan, you have to unmute yourself as well. Dan, 1 second. Okay, Dan, unmute yourself now.
Okay. Thank you, Rabbi. This is really a true honor. As the Rabbi said, I'm newly back to Montreal. I'm born and raised here and did much of my medical training here, but worked in Toronto for 10 years until actually the day before Yom Kippur, when my wife and I decided a pandemic is a good time to move back to Montreal. it's not. But we did it and we're back. And now I'm an attending physician at the Jewish General Hospital. My practice is a mix of geriatrics, internal medicine, and I've been a COVID specialist ever since I was the first COVID doctor in downtown Toronto last year, because I was supposed to be on my honeymoon and I was the only one who didn't have an excuse why he wouldn't cover it. So I'm going to share my slides. I've prepared about just under 30 slides about what I think are important things that we all need to know as we get older. As you'll see in some of my disclaimers, this is not medical advice. Everything I say or everything you do should be done under the consultation of your own physicians. Once I share my slides, I'm much happier if you interrupt me throughout with any questions or comments, but you can also wait for the end. So don't feel bad. We're a small group. If you have something that you want to ask, please do right away. And here's my screen. All right, let's do this one. Now, could everyone give me a thumbs up, or those, if you can't, just tell me that you could see the screen. Perfect. Thank you, Sydney. So this is basically a little introduction about myself. I already told you I started at McGill. I went to U of T, and just so you know, my shul in Toronto was Chabad of Midtown. I had I spent 7 years there. They actually moved around the block while I was there. It was a 5-10 minute walk from my house. Rabbi Nehemiah Deutsch was a wonderful rabbi, and we had always great, warm, high holidays, and I was there for Purim every year. It was a fantastic place. So Chabad is very fond to my heart. Again, I'm going to give you I'll say the disclaimer again. This is general advice. This is not your own personal medical advice. Do everything in consultation with your own doctors. I'm a geriatrician. That's part of what I do. We're here to help. We're always happy to see people. We don't have to see people only when they have problems. We're always happy to do a general overview and see if there's any way we can help you live longer, live better, and live healthier. And I'll give you some tips throughout on how you can do that. And what we do is something called a comprehensive geriatric assessment. So it's not just a regular consult that you get when you go see, let's say, a cardiologist. We look at some other things in your history. We look at your social history, your functional history, and some things that are called the geriatric giants, which is really going to be the focus of my talk, will be the giants, and I'll discuss them next. I'm going to first give you some basic background on geriatrics. I'll give you then the geriatric giants. So these are the big hot topics in geriatrics. I'll talk about your memory, sleeping habits, medication use or polypharmacy, falls, why we fall and how to prevent them. And then the rabbi said you wanted to hear about COVID-19, so I'll give you a few lines on it. Because we're talking about the geriatric giants and we're talking about Chabad or Jews. These are two Jews who played for the Giants. So this is Adam Bisnowadi. He's a football player, and Kevin Pillar, who's a baseball player. He played for the New York Giants and the San Francisco Giants. Here's a little bit of data for our population. Just so you know, this is from Canada. The green bars are basically the percent of the population who's over 65. As you can see, we're right around here. We're about 17 to 18% of the population is over 65. Here, we're here, 16, 17%. This number is a little off. But as you see, we're only going to get older. The percentage of the population is going to keep going up and up and up. And actually, for the first time in history, the aging index has gotten over 1. The aging index means the amount of the population that's over 65 is greater than the population under 18. That has never happened before in Canada, and it's only going to get higher. Meaning, one, people are having less children, but more importantly, people are living longer. And as opposed to, many, many years ago when people, it was rare to see people over the age of 65. Now 65 is young, and we'll see people living a lot longer. Here's another graph. It's even more striking. The sort of lightish green is those 65 to 74. The slightly darker green is 75 to 84, and the darkest colors those over the age of 85. And just look, every population, every age group is getting bigger. So we're getting more people over 65, many more 75 to 84, and an increase of those over 85. When I left Toronto, one of my last patients was the oldest female in Canada. She was 113, living at home. So we're getting older, and we're living longer, and for much of the population, we're living healthier. Now, remember I said 17% of the population is over 65. But when we look at the hospitalizations in Canada, so 17% of us are over 65, but 42% of all hospitalizations in Canada are in people over 65. So there's a disproportionate amount of hospitalizations that occur in older people. I think that's fair and it makes sense. Older people tend to have more medical diseases. They're more comorbid. That's the fancy term for having multiple medical conditions. But here's where it gets even more interesting. Even though older people were 42% of all hospitalizations, they're practically 60% of all hospitalizations. So older people have a disproportionate amount of hospital stays, and then an even more disproportionate amount of days in hospital. So an elderly person is more likely to be admitted to a hospital and then have their admission longer for the same disease as for a younger person. As an example, somebody with pneumonia on average, who's under 65, who needs to be admitted to hospital, which is rare, on average spend 2 to 3 days. Over 65-year-olds spends an average of 5 to 8 days. So you can see for the same disease, an older adult is more likely to be admitted and more likely to stay in the hospital longer. This is just data from my last year in Toronto, which basically again says that elderly adults, here you see it's only 13% of people are over 65 because I worked in downtown Toronto, which tends to have a younger patient population, but they come to the hospital more often and they spend more time in hospital. In Toronto, I was the medical director for Toronto Rehab, which is the largest rehab facility in the world. And we, most of the people who end up needing to go to an inpatient rehab center are elderly people. For every day that an elderly person is in hospital or having bed rest, we quote 2 to 3 days of rehab they need. Now we talk about our hospitals good. And that's a tough one. I'm a doctor, I need business. I need people to come for myself to make a living. But hospitals are generally a very bad place for elderly people. A lot of people like hospitals, they like to stay, they like having a nurse and a doctor and a kosher meal 3 times a day. But it's really, hospitals are only a good place for your acute illness. And once you get better, or even while you're not completely better, but once you're able to go home, the goal for an elderly person is to leave the hospital ASAP. There's so many hazards of hospitalization. That's a fancy term we use for the bad things that happen to us in hospitals. So, one of the things are hospitals are hostile. And we don't mean that, that we're really hostile, but we, especially during COVID, everyone is wearing a mask. So your nurse and your doctor are wearing a mask. It's especially for an older person who has some memory loss. It's a very tough place to be. Depersonalization. So now you're getting meals 3 times a day when we decide So if normally you like to wake up a little later and have, late breakfast at 9, too bad. You're having it at 7:30 with like everyone else. You like your wife's cooking, too bad. You're getting whatever Marnie in the kitchen is making today. So you're not always getting the food you like. Bed rest, especially in COVID, you're not really allowed to leave your room. So now you're just getting more and more dysfunctional. Malnutrition because you don't like the food or people don't like the food, so don't eat as much. Dehydration is very common in hospital. There's just less access to water here. Here's a term, cognitive dysfunction. People tend to get delirious, fancy term for confusion in hospital. It's very common. In the elderly age group, it's about 50% or more will have some confusion in hospital. And polypharmacy is a term for you're getting many medications. So what happens in hospital is people get more and more medications as they're here, and the more medications they get, the worse their outcomes. So we know that when an elderly person comes to the hospital, yes, they may survive. They may do well from their medical condition, but a third of them will have a functional loss from their hospitalization, meaning something in their own life, whether their ability to care for themselves, their walking ability, something is going to get affected, and usually you don't get it back. So once that's affected, it's oftentimes too late. So hospitals are good for what they're supposed to be, but they're not good for you to stay and linger like a hotel. Next, we're going to move on to what we call the geriatric giants. So the big topics in geriatrics, and I'm not going to bore you too much about details. If there's any specific questions, happy to go into it. But I want, when we start, I want to be clear about something, that there are normal changes that occur with aging, like physiologic, meaning that's what God had intended. But most of these changes you should not be able to notice. It should only be a specialist who should be able to figure these things out. For example, and I'm going to talk more about this, but your cognition, your memory. I get a lot of people who come here and say, yeah, I know my memory is going, or I know my wife, my husband's memory is going, but that's okay because they're getting older. The answer, the truth is no, it's not okay, because our memories are not supposed to slip. They're supposed to slip a little bit, but honestly, that's only something I should be able to interpret. Your family should not notice the slight changes in your memory. So every time you have a change, for example, in your memory, it does need to be investigated. There is no such thing as an aging memory, or I'm getting older, my memory's getting weaker. I give an example, if somebody, an elderly person had a heart attack, do we just tell the doctor, it's okay, I'm getting older, I'm allowed to have a heart attack? No, nobody ever says that to their cardiologist. They want to get worked up. If somebody has a stroke, we don't say, it's fine, I'm 75, I'm allowed to have a stroke. It's not true. So the same thing goes, for example, with our memory, with incontinence, constipation, falling. These are not normal things, and they all need to be investigated. Here I just put up some slides. It's just basically showing why our blood pressure goes up, and almost every elderly person will have high blood pressure or hypertension. And then I'm going to talk about some of the more normal changes with getting older. We'll start with the brain because that's a very big topic. And when we talk about the cognition, the lay people usually use the term memory. That seems to be the term that people like to use. Just so you know, memory or short-term memory is only one of the cognitive domains. So the brain has many cognitive functions. Short-term memory is just one of them. Oftentimes, patients will try to, fool us or get around their poor short-term memory by telling us things that happened to them 50 years ago. That's called long-term memory. Just so we know, long-term memory and short-term memory are two totally different things two separate things. Long-term memory is rarely affected when people start having cognitive difficulties or dementia. That's really a much later finding. And when you come in, we have multiple cognitive tests. This is something called the MOCA. It's one of the most famous cognitive tests that was developed here. There's things you may have heard of, the Folstein or the mini mental. We have longer ones that take 2 hours. We have shorter ones that take 10 seconds. There's multiple different tests we do. We have them in English, we have them in French, we have them for people who have university degrees, those who don't even have an elementary school education. So we'll always find the right testing for the right person. And, you know, it's something that we can use objectively to follow people along, because there is no blood test for dementia. Even for Alzheimer's, the only definite test is on an autopsy. So most of the workup is done with our cognitive testing. There's actually 12 things that are evidence-based on how you can keep your memory strong. And this is when you're older, middle-aged, or younger. So there's a lot of things that you can do at any time in your life to keep your brain strong. So these are the risk factors for dementia or for memory loss. Having a low level of education. You know, at your age, there's probably not much you can do for that. Although there's still online courses that you could do. But we know for those who are in the lower socioeconomic status, i.e. those who tend to be poor and have less education, they are more likely to have dementia. Head injuries are bad. For your age group, it tends to be falls. Falls are hitting your head. For the younger populations, those who play pro sports, football, boxing, who tend to have something called CTE, that happens. Air pollution, not much you're going to do. Canada's pretty good about the pollution, as opposed to certain places in China or Mexico. Alcohol is a big no-no. That old one glass of red wine a day is a myth and is not true for heart health. But to be fair, what we know as to be too much alcohol for brain injury is more than 21 drinks a week. So that's 3 a day. I'm sure none of you do that. But too much alcohol is not good. Hypertension, which almost every older person has, is a risk factor that's modifiable, meaning if you take your blood pressure pills, you don't have the risk of dementia. Hearing impairment. I know older people don't like hearing aids. I understand, I see it, but it makes no sense. Now we have these sleek ones that you can barely see. And if you can't hear, you can't remember. And it's one of the easiest treatments for memory loss. Here's 6 more. Obesity. It's never too late to get fit and to lose weight. Diabetes. We can't always prevent diabetes, but then, making sure you take your pills or insulin and modifying your diet is always good. And smoking is not good for anything, but we know it's definitely not good for the brain. Depression is a tricky one. So depression, we know those who have depression are more likely to get dementia, and also people who take certain antidepressants are more likely to develop memory loss. Still, we do advocate in elderly people, if somebody's depressed, to treat it. Physical inactivity is really bad. That just basically means exercise. You're never too old to exercise, and exercise is not 1 day a week for 30 minutes. Exercise at a minimum is 4 days a week, and more likely it's all 7 days a week. And then infrequent social contact or social isolation. People living and not speaking to anyone and watching TV all day are not going to get better. Their memory, they're basically, the term use it or lose it. If you don't use your brain, it's really just going to start having memory loss. So some other things that just came out in the literature. Probably the one food that's most linked to dementia is diet, soft drinks. those are absolute no-nos in middle-aged people. The data is not there for your age group, but aspartame is probably the most offensive food we can eat for our brains. Lack of sleep, new data just came out, a very big study that said more for middle-aged people, 6 hours a night, those who get 6 hours a night are more likely to develop dementia than those who get 7 or more. So sleep is always good. And then offensive medications. I'll talk about the bad medications because many other people are on medications that cause memory loss and not knowing that it causes memory loss. And oftentimes, even when you stop those pills, it's not reversible, meaning you don't gain that memory back. When I see people in clinic, the three things I say at this point, aside from the things I already said, is, have a Mediterranean diet. That's the best linked for healthy brain aging. And we know those who live in Mediterranean countries tend to have a slightly lower risk of dementia. Mediterranean diet, what is it? Fresh fruit, fresh vegetables, and fresh fish. It's not canned tuna or canned salmon. It's, the fresh fish you buy from your grocery store. It doesn't mean you can't enjoy the foods you like to eat. Obviously, cholent is not a Mediterranean diet, but everything in moderation. So yes, enjoy your cholent, your steak, a hamburger here and there. I don't think there's anything wrong with that, but you have to start making healthier choices. Right? So a good diet is one of the best preventions for further memory loss. As I said before, exercise is important. If it's good for your heart, if something is good for your heart, it's good for your brain. We've always known that. And then socializing. People tend to ask, what about doing Sudokus or crossword puzzles or all these brain games that are online? The evidence behind them is practically zero for specific reasons. If people want to do, let's say, crossword puzzles, which are fine to do, that will only help people who have language difficulties. So if somebody has a memory loss or a short-term memory loss, doing a language quiz will not help their brain. A Sudoku, which is math and concentration, won't help people who have language difficulties. So you have to find the right program for your brain. But really, the best thing to do is socializing, because when you talk to people, whether it's your family or your friends, you're using your brain. You're using all parts of your brain. So use it or lose it. Very important. Sorry, I see there's some people who want to come in. Let me just let them in and mute them all. Okay. I'm back. So that's it with cognition. Anything more than that in terms of the workup, that's something we do in the hospital, or your family doctor can do it. There's blood tests, there's medication review. Some people get a scan of their brain. And then there are some medications that can be tried. The truth is these medications don't work very well. Usually the side effect is worse than the benefit, but a lot of people want to try something. And that's okay. If the medication worked that well, we'd all be taking it, right? If there was a pill that improved all of our memories, I'd be taking it now too. So you won't get too much benefit from these medications. Another hot topic that I see is sleep. Sleep is a concern for many older adults, and there's a few things. The most important thing I like to tell people is you don't need as much sleep as you did when you were younger. So as opposed to, a university student who we say should get 7 or 8 hours of sleep, and somebody my age who should get 7 hours of sleep, an older adult really needs 5 to 6 hours of sleep. And obviously it depends on who you are. The reason we get or need less sleep when we get older is because we don't have to recharge as much. Usually you're not running after your children anymore. You're not working your 9 to 5. You're not exercising as much. You don't have as much stress in your life. Your mortgage is paid off. So I'm not saying you don't have stress and you don't exercise, but you don't have as much as when you were younger. So your need to recharge is less. So when I get people in my clinic and say, I'm having trouble sleeping 10 hours anymore, I'm like, so what's the big deal? One of those things to remember is just that we need less sleep. I'll talk to you a little bit about sleep hygiene, and what we see in so many patients are those taking sleeping pills. And there's many, right? There's things like lorazepam and Ativan and diazepam and Valium and Zopiclone and Imivane. I'm just going to say there's almost no indication to take a sleeping pill. It is probably better for your memory to sleep 0 hours than to get a full night's sleep on a sleeping pill. The risks of them are so high in terms of memory loss, falls, fractures, and dependence that I think in my career, I've never started one on a patient. I've been in practice for a decade. So we really advocate people getting off their sleeping pills. And I'm going to talk to you about how to get off of them if you are on them. But first, before giving medications for sleep, we have to talk about how to sleep. So that's something called sleep hygiene. These are basic things. You don't need to be a doctor for this. I'm sure your mom taught you the same thing. So you got to go to bed at the same time every night. That's the best way to develop a pattern. You got to wake up at the same time. We do know there is some evidence that a warm drink before bedtime is good. Obviously not coffee or tea even, but warm milk, that old tale is true. A massage is probably the best evidence. So if your partner can give you a massage, awesome. Exercise is really good because that'll tire you out. But not before bedtime. So no exercise before bedtime. Try not to drink coffee at nighttime, and don't forget chocolate has caffeine. So many people like to have chocolate like after dessert or for dessert. Just don't have it too late. Power down. People like to watch TV right until bedtime. No, not the best. You got to take a warm bath, a shower, read a book before bedtime. Don't take your iPad into your bed. And then the next thing is the bedroom is really for two things only. One of them is for sleep. The other one I won't mention. But that's all the bedroom is for. So when you go into bed to go to sleep, you shouldn't read a book. That's what you do before getting into the bedroom. You shouldn't take your iPad and watch Netflix. You should not get on the phone and start calling people. The bed is really just for sleeping. And then if you can't sleep for 20 or 30 minutes, get out of bed. Start all over. Start the process. Because we know once you can't sleep for 30 minutes, odds are you're not going to fall asleep after that. So it's best to just really start this whole process over again. That's what we do for sleep hygiene. And these are the tricks we would give anybody who's having some insomnia or difficulty falling asleep. These are all the different sleeping pills that people take. Let's see how many people are on. So there's a bunch of you. I'd say at least, a third of you are taking sleeping pills at any one moment. And I'm going to say bad. They are bad. It's sort of like, when your children were growing up and they wanted to do bad things, you would say the same thing to them. You should not be doing these things. And I'm going to say it to you, you should not be taking sleeping pills. And there's many types of sleeping pills. The things that people don't know are alcohol. Some people take a drink before bed to help them fall asleep. That's a sleeping pill. Maybe not a pill, it's a sleeping medication. Some people take Benadryl and Gravol. These are terrible medications for older people, but they take them to help them fall asleep. So avoid if at all possible. This is just one fancy way of tapering. Tapering means, slowly stopping a medication. We don't stop sleeping pills cold turkey. Meaning, if you've been taking a sleeping pill for a year or 5 years or 20 years, you don't stop it because you will probably end up in the hospital from the withdrawal from it. So we do a very gradual tapering program. Like this program takes 16 weeks, right? So about 4 months to taper in. Basically, a red pill, a red circle means a full dose. And this means half dose. So for the first 2 weeks, you take a full pill 5 nights and then half a pill 2 nights a week. Week 3 and 4, you would take a half a pill 5 of the nights, then a full pill, and then week 5 and 6, half a pill. It's just a gradual decline or taper of the medication. I'm going to skip this. I want to tell one thing. As we get older, our bodies are different. You know that, right? I mean, you've seen the changes in your bodies. But from a medical point of view, there's some very important changes on how we absorb medications, especially for those of you who take antacids, or they're called proton pump inhibitors, things for reflux. We absorb medications differently. The way things are distributed in our bodies. So if you look here, as we get older, even if our weight is the same, we have more fat. And that's important because some medications go into fats more likely, and some medications go into water more likely. And so for medications that tend to go into these spaces, they will stay in the body longer and they will reach concentrations at different levels. So it's always important for you and your physician to reassess the dosing of the medications you're on, because they will change with time. And then something as we age is to remember, we tend to become a little more frail. You know, we're not as robust or as strong as we were when we were younger. And sometimes we get too many side effects from medications. So for those of you who take too many blood pressure pills, remember your blood pressure too low is bad too. It causes fainting. And then you could fall, hit your head. Diabetes, if your glucose or sugar is too low, you can have a seizure and you could faint as well too. Cholesterol pills, remember, a cholesterol pill normally works for 10 years from now. So the benefit you get from a statin or Lipitor or medication like that is only going to be for a decade from now. And people get a lot of side effects from them, typically muscle pain and like pain in your thighs. Antacids have side effects. They decrease absorption of a lot of vitamins and
Doctor, someone asked a question. I don't know if you see about melatonin.
Okay, let me finish this slide and we're going to talk about melatonin. Perfect. Thank you, Rabbi. And then one fancy thing that I tell every patient, any new sign or symptom in your body or anything you're experiencing is a side effect of a medication until proven otherwise. Most, you guys tend to be on many medications. They all have side effects. Every pill, that Tylenol you take and that baby aspirin is, I could list you 100 side effects of that baby aspirin you're taking. So just remember, a lot of the things you experience are side effects of a medication. Sorry, I didn't see you. That's probably from the chat group about melatonin. So melatonin, I'll go back to, it's from the sleeping slides. Melatonin is one of the newer kids on the block in terms of sleep. A lot of people took it or still take it to get over jet lag, when flying across the country or across the ocean, pardon me.